So Melody is a licensed clinical social worker and a licensed addiction counselor that works in private practice in Missoula. And really, this is one component of those three variables that we sort of focused on in this afternoon session. And Melody's going to talk a little bit about the how to deal with the substance issues that come up invariably with chronic pain management, especially, I mean, obviously when we're dealing with controlled substances, as well as dealing with essentially non-prescribed substances, and how that figures into the overall picture, and also what the real issues out there that sometimes we don't see. I mean, we see them on a tangential basis. We sort of become suspicious that a patient is having trouble with substances, and we tend to sort of ship them off to somewhere else, and they may go through treatment. I think everybody knows or should know in this room that this focus that we've had in the substance abuse arena in this state has been focused on meth up until this year. And all of a sudden now, prescription medications are the primary focus. So we're seeing a bit of a transition, which I'm afraid is going to make the situation a bit worse before it makes it better in terms of adequate pain control and that sort of stuff. So I think that we're all going to have to deal with that.
Thank you. I have actually been in the field of addiction in various practices. I've worked in publicly funded organizations as well as in the private practice for the last few years. And a few years back, I became increasingly interested in working with people who had developed dependence on prescription medications. In part because they seemed to be a very different animal to me. And what I began to sort of determine over time was that they were often very, very bright people, often professional people. I had a number of professional people in my practice. Often they had multiple issues going on, including a physical issue or a mental health issue. So they had all these different things happening. And treating them was very, very difficult. And I soon realized, which I think probably kind of spurred on some of my passion for trying to learn more about how to work with this particular group, was really the fact that I really didn't know how to treat them. And I still feel like I'm really trying to figure out and learning often from the clients themselves how to best address what's going on with them. And to do that, in part, I had to really begin to understand a lot more about why they were using different groups of prescription medications the way they were, the function that those medications served for them. And I also needed to understand that for many of these individuals, and this kind of goes back to, the discussion about the avoidance of pain and how PT, some of the work around PT is to help people address some of those pain avoidant behaviors, or in some of the behavioral programs, that they have in pain clinics. For these individuals, they're really also very avoidant of affect. They do not tolerate the emotional experiencing of themselves at all. And often, what's been really interesting is that this aspect of them where they don't tolerate the emotional experiencing of themselves was evident in childhood. That often, and it's not always tied into trauma, not always tied into grief. Sometimes it's just the way they were wired. And the way they were wired is that they tended to have more problems with anxiety. And from an early age forward, they often then looked for ways either initially to emotionally kind of check out. In some manner, they would check out. And then later on, what they would do was then fall into substances, where they would then use substances to check out. And then if they happen to develop any physical issues, then that would give them a venue or a mechanism through which they could then have access to the perfect drug if you want to check out. The perfect drug category. numbing, you don't feel anything. And more principally, more critically, what happened is that they could tolerate their affect if they're on opiates or heroin. They could tolerate their affect. They could see what they're feeling, but they were detached from it, and it didn't bother them at all. They could have more energy. They wouldn't feel more depressed. So treatment of opiate addicts is very, very challenging because what you're then looking at is taking away something that they believe helps them to function and have interaction, be able to relate to people, even though, again, of course, over time, they get more and more checked out and more withdrawn into the opiates. But for a period of time, it works for them in that way. So to take that away from them, to put them back into the experience of, back into the physical and emotional experiencing of their body and their affect is something that is very, very difficult for them. So difficult that it's not just the fear of being sick through withdrawal or detox that they avoid getting off the medications for, or getting cut back on the medications for if the attempts are being made to cut back their medications. But but it's also just it's not just a detox of feeling the physical things. It's about being more in their bodies and being more effectively in touch with themselves. So this is very, very difficult for them. And that was one of the things that I, working all these years, 25 years in addiction, I had never really thought about it that way, that there was that particular degree of connect between these individuals and their opiate medications, and why they would do anything. Once they cross that line, why they would do anything, where you'd have people who are business people, and then all of a sudden, tampering with their prescriptions and committing crimes. Anything to get the opiates. So that to me was really different than a number of the other drug categories in terms of the other types of addiction. So I'm now going to try to say a bunch of stuff kind of quickly, and I've been kind of shaping what I wanted to say as the day has progressed. But the other piece that's really critical about this category is how long it takes for them to respond to treatment. Because in some ways, when you get a person off opiates, once you get them off the opiates, which can take a while, or to get them to cut back to a manageable level where they can function more in their lives, which can take a while, it's almost as if they're starting from scratch. So for many people, again, even if they've had professional careers, they may have destroyed their professional careers, and then they're having to start from scratch and learning how to function, how to even create lifestyles that involve, again, from a biopsychosocial perspective, like how they can recreate. They haven't had to recreate for a long time. How they can go out and get a job, be in a relationship, parent children, because they've not done it and dealt with all the emotional experiencing of any of those things, any stress, any anxiety. They have not done any of that. And it's almost like working with an infant. You're trying to work with them on teaching them how to tolerate their existence and how to learn how to self-soothe and learn how to, cognitively work on kind of regulating their emotions better. Because it's not there for them, but particularly depending on when they started using, it is not instinctively, naturally there for them. So this is also a very, very different piece for opiate addicts, which is different than many other addictions. The part that, and I have an outline that was changed. So there should be an outline in your folders that are front and back. And if not everybody has that, there's available for you. but it should be a one-page front and back. So, yeah, and just keep raising your hands and you'll get the copy for it. What's interesting about these individuals is that, you know, what I've been sort of used to working in public, especially in the public health settings, is that you would often work with people who had addiction issues, and not always, but most of the time I would say they kind of look like kind of your gnarly characters who look like they might have addiction issues. And this is not the case with people who have opiate addictions. And again, I don't want to really like stereotype people or overly kind of make it too broad. But this is the thing that, again, is kind of interesting about opiate addicts. I mean, there's a reason why they have 48-hour detox facilities for businessmen. Businessmen are actually one of the most highest represented opiate addicts in professional fields are businessmen. So they can go to these detox facilities, be sedated, you know, and put on naloxone, and then come out of it 48 hours later and be done. So, and keep doing that as often as they need to. But there are some complications, that there are a lot of meth addicts, however, who have now switched over to opiates. And not only have they switched over because now they're in their bodies differently, but they're coming back into being their bodies differently after have their brains being fried. So they're feeling kind of some discomforts in their body that they're never used to feeling. So again, they're kind of maybe more often your gnarly looking people, so they're a little bit more obvious. The ones that are more challenging are the ones who on the surface may appear much more compliant and much more workable. But the thing about the opiate addicts is that because they will do anything they can to protect their access, they are often not what they appear to be. So it makes it really challenging. So I'm going to just sort of talk about some of the warning signs and just sort of go through it rather quickly. And it's not as if, I'm not going to say that it's like any one thing determines that this person has got the red flag on their head. I think it's really more of a collection. And I think often you kind of know, or after a while you're going to get a gut feeling that something is sort of awry and you have to sort of follow your instincts. But among the warning signs that you can look for is those individuals who have their medical care primarily or only provided by emergency rooms or walk-in urgent care facilities. They do not have a relationship with somebody who monitors their medical history over time. They have multiple surgeries or injuries not related to specific ongoing medical conditions. So often what you'll see is people who will purposefully aggravate their situation. Like I have one guy who had pancreatitis, had no symptoms unless he drank. So of course what he would do is periodically he would drink, and he'd end up in the emergency room. Or people who would just do reckless things again, so they would end up with broken bones, injuries, or they would engage in activities to aggravate whatever back problems or whatever problems they had. The third one there is a lack of interest in or follow through with preventative or wellness healthcare strategies. These are people who tend to be much more passively involved in their care plan. They're interested in getting the medications. They're not as interested in doing anything to alter lifestyle. If there's a substance abuse history in the patient or family, that's another critical one. Mental health issues in the patient or family. Repeated interest in treating self or children with cough complaints with codeine cough syrup. I have one patient in particular who I've been trying to get her into having regular allergy shots and taking allergy medication, because in her not doing that, she's always getting bronchitis and sinus infections, going to ERs for pain medications or codeine cough syrup. And so that's part of the more preventative thing. I have other clients who what they've done is they're always taking their kids in for, when they have kids who are coughing, they always get cough syrup for the kids, the codeine cough syrup. So again, I think that really should be a pretty major red flag when that's going on. Patient focuses on physical complaints, requesting increased dosages and other prescription medications to treat symptoms during appointments. Patient reluctant to recommendations of including spouse or significant family members in care plan. I think it's really important, whenever possible, to get the releases signed, to get the family members involved in the care plan. Not just for the collateral information, but so they can also assist in becoming more educated for the care plan for the patient, but then and so they can be supportive in appropriate ways, but also can be educated about what are going to be, again, some of the warning signs that the person is having a hard time managing their pain medications appropriately. Patient is always reporting increased physical symptoms or engaging in physical activity which aggravates physical issues, which I talked about a little already. Patient works in a profession that provides access to prescription medications, like being a realtor, housekeeper, personal care attendant, or nurse. There are certain fields that, again, if there are other kinds of things that you're worried about, their access may be something that may also need to be kind of a red flag that you begin to collect in your head. Medications are lost before refill date. Medications, patient runs out before refill date. Track marks. And I think sometimes in emergency rooms, one of the more challenging things is how to deal with somebody who's reporting a pain issue. And they have, you note track marks on the arm. Do you then treat them or not treat them? Patient utilizes internet to fill prescriptions. Patient, of course, tampering with prescriptions. And patient and family report cognitive or physical decline on medications. Now, I know I'm going to start running out of time here. There's some common responses. It's a lot more challenging, I think, right now to manage patients because and that's kind of one of the points down here is that the clients now in Missoula, and I don't know about the rest of the state, but in Missoula they now have access to methadone and Suboxone licensed physicians. Excuse me. So, and they can also access medical marijuana cards. Now this has made managing these clients and these patients extremely much more challenging and difficult. And that's a whole nother discussion. But if the client's interest, and this is I think it's always the interesting piece about figuring out what the goals of the care plan are. If the client's interest is working on developing new strategies to deal with chronic pain, working with their providers, working with their treatment team to figure out how they can make the most progress with whatever their adaptive plan is that's accommodating all their needs with the least amount of prescriptions or least amount of need for medical marijuana, I think would be the ultimate goal, so it doesn't interfere in their quality of life from a biopsychosocial perspective. Because the more you're using, the more you're having to rely on substances, the more that's going to interfere with how you're doing from a biopsychosocial perspective. But I think that getting a patient to invest in a treatment plan the same way that the treatment team may be invested in a treatment plan, of course, is going to be one of those dilemmas. How to get them invested in the same way. And I'm really a big practitioner of motivational enhancement, and that's where I think it takes a while. Because they're not going to give this up, something that makes them feel so good and they believe helps them function so much better easily. So on the next page or the back, I have the strategies to consider. And again, get back to what I had talked about before, what I really, really know about this whole process is what I don't know. And I've really discovered that I really can't treat these patients as a licensed social worker and a licensed addiction counselor on my own because I really don't know the pain. I don't know the pharmacology exactly. That's not my training. I would tell you that many of my clients, though, have done their research on the internet. They know this stuff. So I think it's imperative that to the degree to which, for myself, I still like to see a lot more training for licensed addiction counselors. But I think what's really imperative is we to find ways in each of these communities to work in multidisciplinary teams. And in Missoula, Tamara Knotts and Dr. Seacreast have organized community meetings so we can kind of come together as a community and figure out in a multidisciplinary manner how to kind of work with these complex pain patients, how to develop some protocols, how to figure out the guidelines or how we're going to do this, because many of us see the same patient. And they're very time consuming, and they're just so hard to treat that unless we really compare notes and unless we can really find ways to work together, I don't think we're very effective with them. So, again, thinking about my sticking point, that's what I was talking to Pat earlier, my sticking point is that I think that we all have a piece of this process. We all have a piece of experience, our own particular discipline that we can really apply to this puzzle. But I don't know that any of us can treat these patients separately. I think that the only way we can effectively do this is by coming together. And I think that, because I do think these patients are manageable if we do it from a multidisciplinary perspective. And I guess that's it. So thank you.
Couple of comments. Can you hear this? Is this working? Yeah. A couple of comments. One thing I would like to point out, and there's no doubt that this population is difficult, and this is a complication, just like anything else that we do in terms of any intervention. Surgery, we deal with infections, we deal with nerve injury, we deal with vascular problems. Everything has a complication. So if you're one of the group that says, I've got a good reason not to prescribe opiates anymore, and that last talk gave you that, then you can probably free to leave for the rest of the day. We don't have to discuss anything else. I think the challenge is really to try to figure out, can you manage the risk appropriately? And I'll tell you something that really, it took me a while to really sort of realize, and that's this. You can get very, very, very good at managing the prescription of opiates. That's a different thing than saying I'm very good at deciding when opiates are beneficial to the patient. And as a part of the overall treatment program, we're gaining something. So just keep that in mind. I mean, we've created systems that are very good at catching people when they're doing funky things with their medications. I still don't know whether they were adequately being treated or not. I don't even know if they were abusing their medications. I just know that they weren't sticking to the rigid protocols that we had set up. Think about that. Anyway, the next and the last talk is going to be by Dr. David Junker, anesthesiologist who works at Advanced Pain Center in Missoula and is fellowship trained in pain management. So Dr. Junker is going to talk to us a bit about what's appropriate and when it's appropriate in the chronic pain context to utilize interventions and what's available for interventions.
Great, thank you.
That second page of the pain session documentation.
Do we have a pointer?
Yes. This thing.
Good. All right. Well, thanks. We're almost there, guys. You guys have done a great job today. Really what we're going to talk about is interventional pain management. What I do want to stress is, I'm sure this has come across really well, that when you're managing these complex patients, it's not, let's try physical therapy and that didn't work, let's try some psychotherapy, that didn't work, let's try this. Really, we want to get the process that we want to try a lot of these things all at the same time. So we're doing interventional management at the same time we're doing physical therapy, the psychotherapy, the medication management. And that's all really critical in managing these difficult patients. I don't know how many of you have seen this, but this is the typical chronic pain patient I see in my clinic, right? What's your pain? 10 out of 10. And they always look the same. So very, very challenging population. So even though I'm an interventional pain physician and enjoy putting needles in people, there is a methodology behind the madness, and really we are trying to treat the whole person, not just the problem. But and finally, just this last slide here with the technology in pain management. Really, over the last 15 years, especially with 15 years ago, a lot of the blocks were all done blindly. Sympathetic blocks, obviously the epidural injections, and now with fluoroscopically guided images, we actually know where we're going with these needles, so it really helps out. All right. So what can an interventional pain physician do for you? Well, there's a lot of negative connotations out there about the interventional pain doc, right? A bunch of needle jockeys, don't treat anything else. But I certainly pride myself on giving my referring physicians, a full diagnostic workup and exam, helping implement that whole multidisciplinary approach that we've talked about today. And just like I said, we use image-guided diagnostic and therapeutic procedures to improve function. And again, function is really the key here. Not necessarily a pain score, but function. And that's critical when you're treating pain in general, and especially chronic pain. So a lot of the interventional stuff I'm going to talk about obviously has to do with the spine, from the cervical down to the lumbar. And when I have a patient come into me, the way I break it down, in my mind, how I start thinking about the different pain generators would be the disc, obviously, so discogenic pain. And then you can have degeneration, you can have annular tears, herniations, etc. You can see here, obviously, the big black dark disc, and they're, a more hydrated disc up here looks pretty nice. But as we get older and they start to degenerate, certainly those can cause problems. We also have the facet hypertrophy, so we'll get into that a little later, but facet syndrome, axial back pain. This is just an axial image of an MRI here. Call this the hamburger sign here when you get this nice hypertrophied facet joint that indicates arthritis in the joint. Spinal stenosis pain. Typically this white area you want to be nice and open. This is pretty squished down here, the spinal cord and the nerves here. That certainly can cause pain. Radiculitis, so any type of pain down the leg, which could be coming from the back, could also be caused by piriformis syndrome. SI joint pain, and then muscular pain, myofascial pain. So those are the things I'm thinking about. Oh no, now we have to go through all this, all right. So I just kind of want to give you guys some case studies of the typical patient that you might see in your clinic that may benefit from interventional management, and also my thought process too when I'm seeing these patients. So here you got a guy who's had 5 weeks right-sided low back pain, goes down to his buttock, down his leg to the top of his foot, has these neuropathic descriptors, sharp shooting, tingling, numbness, that type of thing. Your physical exam, he's got some sensory deprivation there in that L5 dermatomal distribution. He's got asymmetric reflexes at the ankle. At the ankle. And he's got some strength deficits in the toe. So lifting his toe up, he's got some weakness there. It's classic L5 radiculopathy. And as far as his exam goes, his range of motion is somewhat limited, but he's got a positive straight leg raise on that right side. So all these really point to a classic radicular component. And somebody like that, somebody that would really benefit from an epidural steroid injection. And obviously we do the epidural injections in the cervical, thoracic, and lumbar spine. There's two ways to do this. You can do an interlaminar approach, go right in the middle. I call it the shotgun approach. You kind of get the medicine everywhere. Or there's the sniper approach, as some of my colleagues like to call it, and that's more of a transforaminal approach where you go in the neuroforamen and really target that selective nerve root. Again, fluoroscopically guidance, this is a cervical epidural. You can see the needle coming in here. You inject your dye. This is a lateral view. You see it spreading out nicely there. So you get all those warm fuzzies knowing the medication's going in the right spot. This would be from your AP image. This person's obviously had a cervical fusion before. This is just a thoracic epidural. And again, it's always nice to have the AP image and the lateral view because you know exactly where your needle is in that three-dimensional. Try to picture that three-dimensional picture. And this is an epidural in the lumbar spine. And obviously, the other nice thing about fluoroscopy is you can target either more left-sided or right-sided in the midline. Or you can do, as I said, a selective nerve root block. And this would be a selective nerve root block on the left side at the S1 level. And this is the S1 nerve root lighting up here, and then you're getting epidural spread too. So you have a nice neurogram as well as an epidurogram. And then this would be at the L5 level. Again, you have the L5 neurogram and then going into the epidurogram. So you're really confident knowing exactly where you are. And that's really critical because if their pain gets better, you kind of know if you've hit the right pain generator or whatnot. And then there's a caudal approach. So you can go in down low by the sacrum here. Sometimes that's good if people have had fusion surgery. They've had changes in their anatomy, and the caudal approach can be quite helpful also. All right. So next patient here. So this is a young guy, kind of suffered a back injury. Chief complaints, axial low back pain, worse than the right. No radiation to his lower extremities though. Hasn't really responded to physical therapy or other conservative NSAIDs, etc. Pretty normal sensation, neurologically intact, no motor deficits, no trigger points. And the other patient here is kind of the opposite end of the spectrum. So the 67-year-old gentleman who has bilateral axial back pain. And again, pretty normal exam, but pain's a lot worse with extension and rotation, not really responding to conservative management or other medication modalities. So, and the other thing I didn't really throw in here would be the MRI, which would show, on the young person, probably show pretty normal discs, but they have some facet hypertrophy. And on the 67-year-old gentleman, right, is going to have multi-level degenerative disc disease, arthritis, the whole shebang. But the real giveaway there is, pain with extension and rotation. Typically, that's more a facet involvement. And so with these types of the patients, there's a few different modalities that we can do. One is the intra-articular facet joint injection. So tends to benefit somebody who's a little bit younger, more of an acute injury. You put some steroid in there and you can hopefully get some improvement, decrease the inflammation. For chronic arthritis, doesn't necessarily tend to work so well. May still be worth trying. Can be a little bit harder to get into the joint actually. And this is a picture here of, you see the nice facet joint here. So this is your superior articular process of the level below and the inferior articular process, and right between that's your facet joint. So this is the needle going right into that joint. And again, then you put your dye in there and you see nice dye spread. So again, you know exactly, very confident where you are. The other way to approach this is actually to numb up the nerve that goes to the joint. So we have the ability to take the body's ability away to sense pain in the joint. And this is done by doing a medial branch block where you put some local anesthetic on the nerve, kind of runs in this groove between the transverse process and the superior articular process. And you just numb up those joints and you have them get up and you walk around for a few hours and you see how their pain gets. It's only going to work for a few hours. And again, it's just truly a diagnostic block. And if that works, then you can move on to medial branch radiofrequency ablation, where you can actually ablate the nerve and get a longer solution to the problem. Unfortunately, as I tell my patients, it's not a permanent solution. I've seen people get 5 years benefit. I've seen people just get 5 months. My goal usually is to tell them, we're going to try to get you a year. That would be the goal. And we can do this in the lumbar spine and the thoracic spine. And this would, and I'm sorry, not the thoracic, the cervical. Thoracic, you can do it in. It's a little more challenging. Again, just the view of the nerve, the medial branch nerve here, dorsal root ganglion. You heard a lot about that today. Medial branch nerve comes off right there. All right, next case. 45-year-old worker falls on the ice, lands on his left buttock, no fracture. Pain's really isolated to that buttock area. No radiating pain, no tingling numbness. Kind of just describes that deep dull ache. Again, pretty normal exam. But the one thing that's positive is like the Faber exam, or Patrick's. Some people call it Patrick's. So flexion, abduction, external rotation reproduces that buttock pain. Ganslin's test, does everybody know what that is? A lot of you know. So a few ways you can do that. One, you just kind of have them scoot over to the exam table and drop their leg off the table, and it stresses the sacroiliac joint back here. There's a few other tests you can do for the sacroiliac joint, but may have pain over palpation over that joint area here. X-rays may show inflammation. Sometimes they don't if it's more of an acute thing. But these types of patients, a sacroiliac joint injection could certainly help. And again, this is all done under fluoroscopy. This is a picture here. So this is your pelvis coming in, meeting the sacrum, and right in the middle there is the sacroiliac joint. And this is the dye spread from your injection here. If that doesn't work, there's some newer technology out there. You can actually do radiofrequency ablation of the sacroiliac joint. It's a very long procedure. Not a lot of insurance companies are paying for it right now, but it can be worthwhile if you're getting a few months benefit out of these sacroiliac joint injections, but not getting anything long term. This can sometimes help you get a little bit longer term approach to that problem. All right, next case here. So 55-year-old female referred for sciatic nerve pain in her left leg. Kind of has all the classic symptoms. Started after she went on this extended trip, sitting for an extended period of time, not real comfortable seats. She has, classic sensory deficits and an L4-5 dermatomal distribution. Reflexes are actually intact though, and strength is okay. Back exam doesn't necessarily show a whole lot, but she has some symptoms on exam that indicate maybe her piriformis. She may have some piriformis syndrome. So there's a few things you can do to test for that. One is you can have them I need to be laying down, but you can have them externally rotate out against pressure against your hand, or you can internally rotate the hip. That'll stretch that. Sometimes they'll have pain in the sciatic notch. And the MRI of the back is actually pretty normal. So why are they having sciatica, but they have a pretty normal MRI? Well, sometimes piriformis syndrome can actually do that. You can see here the piriformis muscle, how it comes out, attaches to the greater trochanter here. You get the sciatic nerve that goes underneath the muscle, and actually about 11% of people that nerve actually goes through the piriformis muscle. So when you injure that or irritate that muscle, sometimes you can get sciatic pain. And the way we can treat that, certainly the mainstay is physical therapy, stretching, NSAIDs, absolutely. When they get to me, the other option would be to do a piriformis muscle injection. A few ways to do that. A lot of people just do this blindly in their office, and that works well. I just tend to do it in the fluoroscopy suite with a electrostimulator here. So you can place the needle, typically inferior to the sacroiliac joint. You can stimulate that piriformis muscle, and it also makes sure that you're not stimulating the sciatic nerve, so you don't inject in the sciatic nerve. Again, inject your dye, you get a nice muscle spread there. Sorry. And hopefully they do better. All right, next case. So this is a lady who tripped, fell, fractured her wrist, had it repaired 6 weeks ago, healing fine, but has this chronic just burning pain, nothing can touch her skin, the wind blows on it, it hurts, feels like her hand's on fire, changes in color, feels cold. She's got, when you see her, she's definitely has a temperature change. She has mechanical allodynia to light touch. It's non-dermatomal. Anybody know what's going on? Yeah, exactly. RSD, or complex regional pain syndrome, is the other name for it. So if you catch this early, you have a really good chance of actually fixing it. So there's different stages of complex regional pain syndrome. And if you catch it within the first 3 to 6 months, these injections can work very, very, very well. And if you see this type of pain, that's really when an interventional pain physician can help you out and help the patient out. Because if it gets chronic, a year and a half out, these injections don't work as well. For the upper extremity pain, you can do a stellate ganglion block that's up in the neck. It's an anterior approach, usually about C6 or C7. And this is a picture here with our dye spread again. Always have the dye spread, making sure you're not in a vascular vessel and you're getting the picture that you want. For the lower extremity, it's the lumbar sympathetic block, and that's actually around from L2 to L4. Typically, I go around the L3 level. And these are all pretty invasive procedures. Again, that sits anterior to your vertebral body, so that you can see here your needle, you got quite a bit of distance to go to the anterior of that vertebral body. Inject your dye again, make sure you're not vascular. And then the other thing for complex regional pain syndrome, if those things aren't helping, you can certainly do peripheral nerve blocks, supraclavicular nerve blocks, numb up the brachial plexus. You could do femoral nerve blocks, sciatic nerve blocks. Some people will do beer blocks where you put a tourniquet on, you inject local anesthetic into the arm, let it sit there for about 30 minutes. Sometimes that can help. All right, next case. So patient falls, a lot of people falling on the ice. I see that a lot here in Montana. So has this tailbone pain, chronic tailbone pain. What do you do with that? 6 out of 10, again, NSAIDs aren't working. You see these people come in, they're on Lortab, Percocet, ice helps somewhat, but really just not getting any better. So what can we do for them? Well, sometimes it's difficult, but one thing that is worth trying is a ganglion impar block. Again, this is actually the lowest part of the sympathetic chain. This picture may be kind of hard to see, but this is actually the sacrum here, and then you got the coccyx right here, and this is the sacrococcygeal ligament. So the needle's coming through that ligament anterior to the coccyx here in the sacrum, and then you get your dye spread. You just basically put a little local anesthetic and a little steroid in there. And sometimes you have patients that get better. Not all the time, it's not a 100% cure, but it's certainly worth a try. This can also be a block for rectal or vulvar pain because those sympathetic nerves do go to those areas. All right, next case. 58-year-old male has an acute herpes zoster breakout about 3 months ago. Rash is gone, he's all healed up, but he's got this just chronic burning pain in his chest wall. Kind of this T6 to T8 dermatomal distribution. Narcotics aren't helping. He's tried the anticonvulsants, tried the antidepressants. Nothing's really helping him. So obviously he has post-herpetic neuralgia. Now that's not a picture of post-herpetic neuralgia, obviously, but that's an acute breakout. Has anybody ever seen one that bad? Yeah. So options that can help them, if medications, you've tried all these other options, sometimes an epidural can help, sometimes. Sometimes intercostal nerve blocks don't tend to really last that long. Probably the mainstay if you try these other modalities, and some people go right to a spinal cord stimulator. But a spinal cord stimulator can really be incredibly beneficial, and you can really get usually good capture with this type of a problem. Here's a 45-year-old woman. She's got chronic neck and occipital headache pain, worse than the left side. Just has been getting worse over the last 3 years, no trauma. Kind of worse with extension and rotation with her head. And it kind of radiates up in this distribution, kind of up and over, up into the temporal area, but always starts in the occipital area. No evidence really of like a migraine type headache, no vision changes, no auras, nothing like that. She's taken opioids, she's been cycled through all the doctors, right? NSAIDs, opioids, Maxalt, all that type of stuff. When you examine the patient, she's got reproducible pain over the left greater occipital notch area. And you can actually reproduce it in that same distribution. And also with the extension and rotation. So this is a type of patient that has pretty classical occipital neuralgia pain. Sometimes it may not be necessarily the greater occipital nerve. Sometimes it can be caused from your upper cervical facet joints. Specifically, there's the third occipital nerve that goes up and branches up into this area that comes off the C2 medial branch nerves, or the C2 facet joint. C2-3 facet joint, sorry. So treatments for this, for greater occipital neuralgia, you could just simply do a block right in your office. Just inject some local anesthetic back here in a fan-like distribution. Could put a little steroid in there, and sometimes that helps. How many people do that in their office, this type of problem? Yeah, it works pretty good. I mean, sometimes you can totally take care of their pain. If that doesn't work, it may be worthwhile doing, again, the medial branch workup, where you do medial branch blocks, and you can even do radiofrequency ablation in those upper facet joints. And the newer things that are out in the last several years are actually placing stimulator, nerve stimulators, implanting them across capturing the greater occipital nerve up here. And that's really the newest thing that's out there for this chronic cervicogenic headache type pain. All right, osteoarthritis, obviously we can do all that. Hip injections, knee injections, shoulders, steroids, the Synvisc, Hyalgan, we kind of touched on that earlier. 24-year-old female here with chief complaint of chronic pelvic pain, my favorite. Right, tough pain to treat. Said it came on after delivering her daughter 4 years ago. She's had the extensive workup, the whole thing, everything's negative, diagnostic laparoscopy, everything's negative. She's failed multiple medications, cycled through it all. Now she's on OxyContin and gets referred to you because the primary care doctor says, I have no idea. I'm tired of her calling me. Take care of it. So what can you do? Well, sometimes it's very, very, very difficult. Sometimes you can, I'll occasionally offer somebody a sympathetic block. Again, how I talked about the sympathetic blocks for complex regional pain syndrome. Some people think, well, maybe there's this kind of sympathetically mediated pain in the abdomen or pelvis that's going on. And you can do a superior hypergastric block, which is around the L5 level. And I have had patients that actually do this and they get a few months of relief, and you do it again a few months later and they function improves and everything else. So it's probably worth trying sometimes. Sometimes people have talked about putting spinal cord stimulators in. I think that's probably not what most people do. I don't do that. Some people have put intrathecal pumps in, and sometimes that works, sometimes it doesn't. Again, a really tough problem to treat. All right, 52-year-old male diagnosed with pancreatic cancer, suffering from horrible abdominal pain, radiates to his back, MS Continence, 80 TID with dilaudid for breakthrough. He's on Lyrica. What else can we do? What else can we do for him? Well, we talked about sympathetically mediated pain, and the way to actually treat a lot of this abdominal pain, especially with pancreatic cancer, is you can actually, instead of putting local anesthetic in for these sympathetic blocks, you can use alcohol or phenol and actually kill those nerves, in essence, is what you're doing. The problem is it's not permanent, because those nerves regenerate in about 6 months, sometimes sooner, and the pain can even come back worse when it regenerates. So doing these blocks, it's really more of a end of life care, typically. So for pancreatic cancer, upper abdominal pain, celiac plexus block certainly is excellent. Sometimes if they have a horrible, maybe they have pain that's got metastatic disease to the spine, and they've got it compressing the sciatic nerve, and they're having chronic pain. Sometimes you can do a lumbar plexus neurolytic block, and you can do it for all any of the sympathetic parts. You can also put in the intrathecal pump, would be another therapy, an intrathecal pain pump for cancer pain. Typically, if they've got more than 6 months to live, that can be a great therapy. And this is just same old pictures, the Medtronic. This is the Medtronic pain pump. All right, moving along. 32-year-old male strained his back, lifting a heavy box at home, mainly left-sided. Describes it muscle spasm, ache, occasional burning pain, real stiff. He walks in, he's real stiff. MRI's pretty normal, nothing significant, no neurologic motor deficits. And an exam, he's just got tight palpable bands, trigger points, very tender when you touch him. So, clearly, a muscle strain, myofascial pain, right? Acupuncture cures everybody. So, and I'm sure a lot of you do. How do you treat this in your office? I mean, obviously, we all know the medications, physical therapy. Trigger point injections certainly can be helpful. If trigger points injections are helping, but it's not helping, getting long-term benefit, sometimes in the chronic patient, you can do Botox. Acupuncture certainly has been shown to help with myofascial pain. Some people do an electroacupuncture, basically put the acupuncture needles into the muscle band, and you can hook it up to like a TENS type unit where you stimulate the muscle. It's like a 20-minute treatment. That can be an option also. All right, 38-year-old, 5 minutes, we're doing good here. 38-year-old male has undergone a previous fusion, comes back a year later. He is just having horrible, horrible leg pain. Goes down the leg, right in the L5-S1 dermatomal distribution. He's got asymmetric ankle reflexes, strength's intact. The surgeon says, I don't have anything more to offer him. He's on all the opioids, the whole shebang. What do you do with this guy? So this is a perfect candidate actually for a spinal cord stimulator. So spinal cord stimulation is excellent for neuropathic pain. That's why there's the fire there, neuropathic pain. So it doesn't really work well for somatic pain, but for neuropathic pain it can work very, very well. So a lot of the main indications would be like failed back surgery syndrome. So somebody's had surgery but they still have this chronic radicular pain. Can work excellent. Complex regional pain syndrome we talked about. So your medications aren't working, your sympathetic blocks aren't working, they can really respond well to spinal cord stimulation. And then we also talked about post-herpetic neuralgia would be another indication. There's a few companies, 3 main companies out there. We actually have 2 of them here today, Medtronic and Advanced Bionics. They all do a pretty darn good job. So basically you place those electrodes, typically you do a trial first, place those electrodes percutaneously, get them right next to each other, get good stimulation in the operating room or surgical suite, and then you have them try it out for a week, see how they do. And if they like it, take them out, and a few weeks later you can go back and put a permanent implant in. And that's about it. I didn't really get too much into the pain pump question, but I'd be happy to address that in the back. All right.
So for the last segment, what I'd like to do is sort of get some feedback from the audience. And the speakers are here as targets for you to some degree. That doesn't mean that this discussion is really you asking the panelists questions necessarily. We would invite anybody from the audience that wants to comment on any of these cases or anything, any questions or anything. But we're going to use the cases primarily as the starting point to do this. So Kay is going to get me is that a copy? That's a copy. Oh, thank you. Yeah. So Kay's getting me a copy, but I will steal Dr. Davis's copy first. So case number 1. Miriam is a 72-year-old female who is complaining of increasing mid and low back pain for the last 6 years. She has a history of degenerative scoliosis, first diagnosed at age 62. She consulted a spine surgeon 7 years ago and was told that she was not a surgical candidate at the time. Her symptoms are back pain that affects the entire lower thoracic and lumbar spine and leg pain radiating to the right thigh and right foot. She lives alone but is finding it harder to manage her activities of daily living, and she isn't sure that it's all worth it anymore. Otherwise, she is in fairly good health with well-controlled high blood pressure and hypothyroidism for many years. She is seeing you asking if there is anything that she could do to relieve some of her pain. So, first of all, what don't you know about this lady? So, what her back looks like. So what the anatomy, what the physiology of the situation is. We know she's got scoliosis. We can sort of infer some things from that, but we don't know exactly what the physiology looks like. What else?
What has she tried for pain up to now?
Correct. We don't have any history. We don't know anything about her in terms of what she's tried or from an intervention standpoint, from a medication standpoint, or what. What else would you like to know about this lady? Okay, so we don't have a bone density scan, so it's important to know what's going on. I mean, she may have acute pain right now that's a compression fracture.
Social history.
mean, she lives alone, she doesn't want to, she's not sure it's worth it. Are there other factors that maybe?
Well, and the question is if she doesn't think it's worth it all, exactly. So all of a sudden she's telling you something interesting here in the sense that there's more to it than just her back pain. What else? Yeah, she wants, yeah, absolutely. I mean, you don't know what her activity level is. You don't really know a lot about her in terms of you don't have a good feel for what she means by pain at this point. What else? Good point. Or if she's a cat person. What else would you like to know?
What's her symptom response? I mean, is it the same all the time? Is it worse when she wakes up? Is it worse when she's sitting down? When she's standing up? When she walks? I mean, that's a huge factor.
Okay. Well, let me tell you this. Let me tell you that her DEXA scan is just borderline low. She doesn't have any sort of compression fracture that's acute on her MRI scan. Her MRI scan shows several areas of facet joint arthrosis. She's got bone on bone at several areas in her scoliotic curve. She's got several areas that are questionable in terms of spinal stenosis and foraminal stenosis on the right side. So now you've got a little bit more of a picture. This lady is a teetotaler. She's never drank in her life. She's never smoked in her life. She's never taken a pain medication in her life because she always was scared to death of being addicted to those evil medications. Well, the scoliosis was first diagnosed at age 62, so 10 years ago was the scoliosis. She increasing mid and low back pain for the last 6 years. So she's really sort of progressed over the last 6 years.
But when did it get to the point that she didn't know if it was over?
6 months ago.
How about what would she see as acceptable therapies?
Can you repeat the questions, please?
Yeah, what would she see as acceptable therapies? So right now she's already told you that she's scared to death of that OxyContin stuff she heard about.
Steroids.
Mm-hmm. Yeah.
What's worse, the leg or the back?
It's equal. You know, when she sits, she's got really bad back pain. She goes and lays down from time to time. When she walks, the leg pain gets worse and the back pain gets worse. She can't walk but 3 blocks, and then the leg pain gets worse.
And is the stenosis facet, disc, or ligamentous, or curvature?
All of the above.
That's how I got through school, yeah.
Or C. So how, I mean, yeah. Yeah, got dorsalis pedices that are bounding. And the skin is nice, and she's non-diabetic.
Is she sleeping well?
Probably not.
What's her family support?
One's a lawyer.
Treated very carefully.
Who dotes on her. It's her favorite child. And she doesn't know how she can live without her mother. And a son that's not there a lot. What do you want to do next? I mean, this person just walked in because she heard that you were the new doctor in town and that you might have some answers for her. So I mean, let's just walk down the physiologic and, you know, first let's eliminate the whole notion of substance, I guess, in this case. Here's a 72-year-old female that's never, on the surface, has never had any evidence of any sort of substance problem. So is that relevant in this case? Why is it relevant? What's that? Okay. But are you worried about sending her for a chemical dependency evaluation before you start opiates? Okay, so we're really interested in, from that standpoint, in this case, we're really interested in the issues about how the medication is going to affect her, not necessarily whether we're going to make her an addict or anything like that. What do you guys think? I mean,
In addition to the medical, I would say psychological assessment.
Speak loudly, because you don't have a mic.
I would recommend, I'd recommend the biopsychosocial, where really looking into how she's feeling about being, what her social supports are, and kind of evaluating that whole piece in terms of whether or not she can get more connected, and then also evaluating the depression piece and seeing if that needs to be addressed medically or with therapy.
is this on? Yeah. When you're dealing with elderly patients, and I guess I'm more talking to the folks that deal with a geriatric population, do you treat elderly patients from a psychological standpoint any different than you do the normal run-of-the-mill person that comes in the office? Yeah. How so? I mean, I'm talking about from a neurobehavioral standpoint. What are the key issues with the elderly that are a little different than most folks? So I'm hearing some things. Social network is one. Next.
Their physiologic, their renal and hepatic metabolism, you got to think whatever you're going to give them, may not function. They make it toxic easier.
Exactly. Yes.
The other thing, they're actually very, very, very responsive to psychological intervention and behavioral intervention, even more so than some of the younger patients. So it's a modality that I don't think we use very often with older patients, but it's really key.
Yeah. Anything else?
I'd like to know what her nutrition, weight, and muscle tone look like, because kind of implicit, it sounds like she might be motivated or something like that there.
Well, she weighs 132 pounds. I mean, she doesn't do a lot, so her muscle tone. She doesn't really use a walker, but she uses a quad cane. So
her activity level is reduced probably because she's not mobile.
well, yeah, and is this, I mean, this lady, when you said, have you ever been to physical therapy, she said, what's that? So part of the question is this, is physical therapy something that these sort of folks will respond to? The other thing that I would probably bring up is that I think that in the geriatric population, she's got it.
No. Thank you.
The one thing that I would probably point out, and I would ask any of the psychologist in the room, we've become very cognizant of trying to understand in our geriatric population what the cognitive status really is, because it plays a huge role. We've gotten to the point where we're pretty quick with anybody that has any sort of indication that they're just beginning some degree of dementia to get a neuropsychological evaluation to really understand as we go forward what our interventions are likely going to be received as and get a little better idea. It's amazing how many times you go down the path of dealing with a patient that you think is pretty well there, and the more you start to do things with this person and do to them, they begin to sort of unravel a little bit more. So we're pretty quick to go ahead and get a formal neuropsych eval and really try to understand. I've found that the neuropsychologists are very good with the geriatric patients to help with that family planning, help the patient, help us make sure we're not making mistakes as we go forward, and especially with medications and those sorts of things that can tend to sort of tip them over the edge. So any comments from any psychologist? You want to jump in?
Well, I just agree that type of assessment's important to be helpful.
I'm just agreeing that that type of assessment is important and can be helpful. And as I think is always the case when psychosocial issues are involved, at an early stage when you suspect there's those kinds of problems, it's good to get it assessed.
Any other comments? Yes.
I'm just dumb enough to recommend that she have a thorough physical examination, including a gynecologic exam.
You mean actually touch the patient?
Actually, I mean, I know what our focus is here, but this is exactly where we make mistakes, is we assume things. And it's amazing how much you find out when you actually examine a patient.
Yeah, agreed. So I guess, yes, go ahead.
I just have a question about neuropsych evals. I know they're very, very expensive, and the one thing that we have that has not been brought up at this conference yet is the barrier of cost or coverage. I know we kind of alluded to it, but it's hard for me. How do you use that? How is that? How can I justify that to some kind of insurance company who undoubtedly is going to say, forget it? And the cost seems pretty prohibitive in the little bit of information that I have here, between $1,200 and $2,500, depending on how many hours it takes to administer the testing. So if you can comment on that.
It's a bargain after you do 3 epidurals and realize, or some sort of intervention and realize that.
Procedures get reimbursed better than talking
Right.
to the patient. So.
True.
I think if you have a relationship with a neuropsychologist, you can get a relatively brief initial screening done, which would be less expensive and would provide the justification for more comprehensive evaluation if in fact it turned out to be indicated.
And then how do you use that other than the obvious of dementia or?
Well, if it appears that the person's having some fairly significant cognitive deficits, you'll get that feedback back from the neuropsychologist, probably along with recommendations along the lines of involving family members in meetings with the patient, so that there's someone else that can carry home treatment recommendations and make sure they're followed through with. In some people's cases, it may be useful to reduce recommendations to some kind of simplistic written format that the patient can take home and stick on the refrigerator with a refrigerator magnet. Different types of strategies for helping the patient to manage the situation better. And the neuropsychologist, by pinning down the particular nature of the cognitive deficits that the patient is having, can kind of give advice with regard to tailoring those kinds of specialized interventions.
Pat, you may be able to, I'm sorry, Davis, over here.
I hear you. There you are.
Don't mean to cut you under. What you may be able to do is an end run. There's the insurance company may pay for a speech therapist to do a RIPA-G and a mental state exam, and then you may be able to at least get a ballpark and then go and do a full-blown neuropsych.
Sure.
Yeah, and I see demented patients all the time, along with all the pain patients that I see. And there are actually some easy screening tests that you can do in a primary care setting that I think we as primary care docs should know how to do, and that can actually guide us. And also taking a good history, not just from the patient, but from the family, can really guide us as to where we need to go with that patient.
One other question, and let's.
I just love to talk about this one just because I can't even sit in my chair thinking if people are leaving here and not realizing this is just an ideal candidate for physical therapy. If this is a mechanical back pain, and obviously you would have asked a few questions and seen that this person, it would be crazy not to send this person to physical therapy.
Could you do the psych eval while she's
You know that slide that Dr. Davis had of all those forms? We give them a stack of forms this big to fill out. They're all those tests. Takes them weeks.
Occupational therapy can do that. So you can.
Yes, ma'am.
I was just wondering if you work with occupational therapists to do home modifications.
I have. Right now, we don't have an occupational therapist that I work with regularly. My wife's an occupational therapist. I'm trying to get her to come work a day a week with us so that we could do that type of thing. I've actually gone into homes myself and done some of that stuff. But yeah, I think any other hands that you can put on the problem will help.
Let me ask one thing. Here's one other question, I think, in terms of the issue about surgery. I'm glad you raised your hand. You might want to jump in on this one. You know, I see this all the time. I see folks come in and they say, you know, I went to a surgeon 10 years ago or 7 years ago, and he said I wasn't a surgical candidate, so for the rest of my life, I'm no longer a surgical candidate. I mean, would anybody send this lady to a surgeon and say, God, it's been 7 years, why don't you go check it out? What do you think?
Well, I mean, I would just say, I was going to dissent. I really wouldn't send her for a psych eval at this point. I mean, she's depressed. We know that already. So she hasn't had any non-steroidal. She hasn't had any physical therapy. She wants to walk out of your office thinking that something's going to make her feel better, and a psych eval is not going to do that. In the short term, it's not going to happen. If her cognitive assessment is okay, I'd try those two things. I'd ask her if there were a surgery available to you that wasn't too risky, would you want to consider it? Because that's going to affect the rest of your workup. If she can't sleep at night and your simple maneuvers, the non-steroidals and the physical therapy don't facilitate her sleep, you can always add an antidepressant to help facilitate pain management in the sleep. So I guess I wouldn't start with a psych eval.
But you're not opposed to surgical?
Not opposed to it.
I mean, a surgical. You're not opposed to sending her back for another surgical opinion?
No, I would encourage that if she is willing to consider that option. She has what sounds like mechanical back pain.
But she got that right leg and right foot pain.
Yes.
So the question now becomes, do we start with non-operative stuff? Do we send her for an epidural? Dave?
Well, you know, I think you just discussed that with the patient, but I think certainly trialing some physical therapy, some medications first are reasonable. You could also do that in conjunction with an epidural, but I certainly think she would be a candidate for an interventional, pain procedure.
Let's talk. Question.
I'd go back to the beginning because this patient has failed with other providers. She's hopeless, she's helpless, she's not sleeping, she's frustrated with where she's at right now. So somebody has to build rapport with her, get that paradigm shift going, because regardless of where you go from there, it's not going to work anyway because she doesn't trust anybody. And she has to get some sleep on board, and so the physical exams are a great place to start, get her sleeping and start building on those other things, and along with the emotional part, again, using the medication that will help with both emotion and sleep sometimes can be a great starting point so you can build on the other stuff.
So on my ideal dashboard where I've got physiology, neurobehavioral, and substance is down there around 0, right? Well, for somewhere. And what you're saying is that neurobehavioral is 75% and physiology is 25%.
Well, I'm saying you have to pull together at some place, but at this point you have a patient that's already failed the system.
Okay, granted. What else? Let's talk about medications. I mean, because one of the issues always with patients in this age range is their sensitivity to medications, and what are you going to start? I mean, this lady's there, as Dr. Gorsuch said, wanting some relief now. When she leaves the office, she wants hope that she's come to the right place. She wants a plan, and she wants some short-term relief. So is that accurate at this point? Yes. And let's assume that we've ruled out any medical problems that are really a problem. She is as presented here, and we're just we're taking everything at face value, and she's not demented, and we're trying to treat her. What are you going to start her on? What are you going to focus on? I mean, you mentioned non-steroidals, right?
Yes.
I'd risk the wrath of the FDA and consider Tylenol plus physical therapy.
Okay. Yes.
I also had an antidepressant, either sort of Cymbalta or tried Dicipramine for her to help get her some sleep, and antidepressant. That would be one of the first things I would do.
All right. Yes.
Least interventional.
Yeah, so if she's against the pills, would she be against the different compounds that are available, the creams and stuff?
No. She likes that stuff. Estee Lauder.
least intervention with this woman will build the best rapport. And she might get a good result out of a silly thing like a lipodermal patch. You know, but the thing is, the more you try to invade her, I think you're going to drive her away.
That's fair enough. Last minute comments, and then we're going to move ahead.
I think you should start with educating this woman to the benefits of the medication and address her fears. Perhaps once you know that, then you can move ahead.
Okay, fair enough. Build rapport. One more question or one more comment, and we'll go to the next case.
That was part of what my comment was going to be. And once that physician has established that rapport, if the initial, more conservative interventions haven't taken place, and there's still the depression and the antidepressant hasn't significantly so then again, I think it's a referral to pain management psychotherapy. And part of the focus there is the fact that she's lived 72 years. She has coping skills. She has ability. She's gone through difficult times in her life before, and you can validate that. And that this may be another difficult time, but you've made it this far. You can address this through validation, affirmation, building coping skills.
Okay. All right, case number 2. Roger is a 52-year-old male that injured himself while working on a highway construction crew. He is currently complaining of low back pain without leg pain. He has been off work for 8 months. Injections have not helped. He was told that there is nothing wrong with his back, that surgery will help. He states that he has always been a hard worker, and this is the first time he has been disabled since he started working construction at age 16. Now he finds himself constantly arguing with his wife because the pain is too much for him to help out around the house. He is spending more time at the bar. He is sure there is something that is wrong in his back that has not been discovered, and if someone would find out what is wrong with his back and fix it to make the pain go away, he would be able to return to work and everything would be fine. What else do you want to know? How much does he drink? None that are prescribed.
Could you repeat what that was, Randy?
What's that?
What did the gentleman say?
What medications is he on, or is he just self-medicating with alcohol, etc.? So he drinks a lot.
I want to know just a little about him vocationally wise. You know, I don't know that you could sort that out at the first visit, but I'd at least explore that. Did he like the work that he did? Does he want to go back to that work? I mean, what does he think about re-education? Just his basic attitude.
He's worked for 2 companies in his whole career, from 16 to 52.
But what's his family history?
What does he want to do going forward, though?
He wants everything to be okay.
Right. Well, I usually ask those people, if it's not going to be okay, what would you do? And I don't push them at the first visit, but if they're willing to go there, I will ask them.
Okay, fair enough. What else?
What was the family history of abuse?
He's not saying.
Is he on workers' comp?
Yeah. He's been on work comp for 8 months. He's been off work for 8 months, and he's on work comp.
I'd want to know if he's willing to see a counselor, and if he is, then send him to Dave or Melody.
Or both. Yes?
An alcoholism questionnaire would be appropriate.
Agreed. Never had a problem with alcohol. Drank pretty heavy when he was a young whippersnapper, but had his first child at age 21. Pretty much just was a social drinker up until about 6 months ago.
Social has different meanings.
Drank 4 beers a week for 30 years. But before that, the 3 years before that, whew, boy, it was binge drinking. Now he's into the hard stuff.
Actually, along those lines, again, I don't know that you can do it at the first visit, but it sure would be nice if his wife would come to the second visit.
Agreed.
But you can work the cage into your initial interview very easily.
Right, right. Yes, ma'am.
You mentioned that he wasn't taking anything prescribed. What does that mean?
He wouldn't tell us. He refused on the first visit. He said he'd come back to do one later.
Is there a certain movement that causes it to be worse?
Extension. When he stands and walks, it hurts. When he rides in a car, it hurts. But it doesn't really get down in his legs, it just stays in his back. I mean, what do you know about this guy? Where do you think he's at right now?
Got a history of PTSD or anything like that?
Not really. Never got a GED though. No, he was a concrete guy. He did not do the books. But he's a good worker. He was a good worker. He was the guy that you know, if they wanted something done, he was out there. He was the first one in line to do it. And, you know, he was there.
What workup has he had done already?
Well, you know, he sort of got put off work, and then because of delays, he's been through physical therapy one time for 6 weeks, and that didn't help. He had had a couple of injections, which really didn't help, and he's waiting on his psychological evaluation because work comp has not approved it because they don't think this is a psychological problem. Yeah.
Are there any particular circumstances around his injury, time of the injury, and are there any family issues?
Well, there wasn't any family issues, but he was really starting to have trouble with the crew because the crew that he was a foreman, and the crew that he was working with, he couldn't keep up with those younger guys.
Does he overweight?
Yeah, he weighs about 230. I don't consider that overweight, but what's that? He doesn't smoke. He did at one time, probably for 20 years, but he did quit, and he's tobacco free now.
So if he's not overweight, then is he 15 inches too short?
I think for my perspective here, this is a great example of where you should say, okay, so what are our goals? Failing physical therapy doesn't tell me very much. Instead, it's like, did you make any progress? So what is it you can do? Can you walk for a couple blocks? Are you doing that every day? Are you doing that several times a day? Getting into specific questions, setting measurable goals that you gradually increase to build somebody's self-efficacy, their belief that they can accomplish things that they need to accomplish. Now, this is a person that for 36 years has done very serious, intense, heavy physical labor, and now he does little things and it hurts. It's very easy to just give up and say, I can't do anything. Well, I mean, maybe the better choice is cut it back a lot, accomplish something, be successful, then move it forward. And I think that's the physical therapy end of it. I mean, you know, it's so basic and it's so boring, but it sure goes a long way.
And just to tell you, I mean, this guy's got a typical MRI scan with degenerative disc disease, nothing that you could really look at and say, gosh, you know, you've got 4 discs there that are bad. You don't really have any foraminal stenosis. You've got facet joint arthrosis, and he's got axial back pain. There's no leg pain. He's got axial back pain. Yeah.
Has he got Cowboy Joe syndrome?
But without the severe injury that Cowboy Joe had. I mean, Cowboy Joe was a paraplegic. This guy has axial back pain and is off work for 8 months. He's in the work comp system, and nobody's really driving this guy to do anything. He's 52 years old. He's you know, his notion of efficacy is bending over and getting his crew to get on that concrete job and getting it done by Friday afternoon so he can go home. And now he doesn't do that anymore.
What sort of injections did he fail?
What's that?
What sort of injections did he
He had facet joint blocks twice, and he had 1 epidural steroid injection. Yeah.
I think the money's in the psychosocial.
psychosocial. And somebody has to get on the horn with workman's comp and convince them of that, because they could, if they understand that they can go down a plethora of different roads with this guy and spend lots of money that isn't going to work based on the information you're going to get from a good neuropsych workup.
Okay. So what are we going to do? I mean, what's the first, this guy's been sent to you as a referral 8 months into this because, everybody at this point said, he's sent to you for an independent medical evaluation and says, can this guy go back to work, which is the norm. So you're the guy, you're the physician or whatever that's seeing this fella with this scenario. You're asked, what should we do as an independent medical examiner? He failed injections. Nobody thinks he's an operative candidate. Here's the situation. What do we do? Could be that, yeah.
If he really is not an operative candidate, then I think you have to ask him what his plan is. And this man's a high risk, that's for sure. And he needs a full, in my mind, he would need the full bore psych eval, intervention, and counseling. And you need this. I think you would need to stress that he's not damaging things when he hurts more. And you need to get him to physical therapy and moving and have him cooperate in formulating a plan with you. And if he's not, my view would be, if he's not willing to start to formulate a plan or even think about how to formulate a plan, at least I'm not going to get anywhere with it.
Right, but what if I told you this guy was a pillar of the community that up until 8 months ago, he raised 3 children, put them through college, and until this episode was a critical member of his community?
It wouldn't change the basic plan and his need to cooperate.
Agreed. Agreed. Yes.
I just wonder about getting him back into a work-related situation, getting back into something that's productive, return to work in any context that might help with his overall sense of himself in terms of being a member of society.
Yeah, and I guess not to belabor this, we got to move on. Yep.
Randy, with it coming to the Jesus meeting, seriously, he's at MMI with conservative management.
Right.
And we could close this case right now.
Right.
And just set him down and say, look, this is where you are now.
Right.
Because he's going to have to buy into whatever you're going to put up there. We got to have him buy in.
I totally agree. And the reason I threw this in is because anybody that sees workers' comp has seen a gazillion of these people go through their office. And the biggest issue that I wanted to sort of bring out is that there's a couple of issues here. This is, in some ways, you could argue that this is an iatrogenic spiral caused by problems that are beyond this gentleman's ability to cope with, and we as a system are not dealing with this well. This guy is a guy that is eminently retrievable. If we can find some way to do exactly what you said, somebody's got to take an active interest in this gentleman and sit down and have the come to the deity of your choice meeting with him. Because he's not capable of doing it himself. And it's part of the disease process. The biggest piece that I see and the disconnect is that it's all part of the disease process that we're dealing with. And somebody needs to recognize that and try to intervene with all of the things that he's incapable of doing. We sort of say, it's your fault, you need to do this. It's the old getting should on again. And somebody needs to sit down and really help this gentleman figure it out. Yeah.
Thanks for continuing with him just a second. With the workman's comp, this is a gentleman who's clearly disabled, where it's coming from, and he's failed the system for surgical, pathophysiologic, radiographic indications for this. Do you find it's realistic to counsel him just directly and say you need a neuropsychiatric evaluation because you're disabled? And is it realistic to expect his disability or workman's comp to continue once the treatment is proceeding along those lines? Will workman's comp say this is not a structural injury, we won't cover this?
Well, they'll try. I mean, and then obviously all these folks get sort of wrapped up in the legal system with attorneys, and then it gets really messy. But what normally fails is that the attorney is the person that then begins to, in some ways, direct their medical care. And all of a sudden, we as physicians, have in some ways abdicated our responsibility to actually sit the gentleman down and have an authentic relationship with him and say, this is where you're at, and let me help you get out of this place. The attorney will do that. But generally speaking, what I've seen in the past is that then it goes down a thing, let me show you how to get the most money out of this so that you can protect yourself into the future. That's not necessarily the same thing as making him functional. And they're doing it because they think they're doing it in his best interest. It's just a difference of sort of what we consider his best interest. So anyway, let's move on to the next one.
Randy, if I could just make 2 quick points in this case. Sorry about that. But one is I think that this case illustrates really well the importance of identifying people who have psychosocial risk factors early on and getting that referral process started to get psychosocial intervention going as a part of the overall treatment plan. The second is in direct response to your question, and that is I think that you can frame these things in such a way to workman's compensation and to insurance companies even early on in the process, such that the development of these psychosocial factors that complicate the person's recovery escalate out of the injury and are injury related, especially if it's a person who was a pillar of the community and was functioning really well in many respects prior to the development of the injury. So if you argue it that way with the claims adjuster, it's been my experience in the past anyway that you can get psychosocial evaluation and intervention authorized. The only drawback is that people tend to wait way too late in the process to do that.
Well, let's do one more, and we'll, if you want to continue, I'll do the fourth one. But let's do case 4 instead, because I think this is more demonstrative of one of the problems I want to sort of focus on. James is a 35-year-old patient who presents to your office to establish care for chronic pain. This patient has been under the care of a pain doctor in another state for chronic pain due to degenerative disc disease of the spine and fibromyalgia. He has been on a stable regimen of care for the last 6 years and brings his records with him to the visit today. There's a letter from his previous doctor that states that James has been a compliant patient with no evidence of drug-seeking aberrant behavior. James is currently taking OxyContin 80 milligrams 3 times a day, Dilaudid 8 milligram tablets up to 8 times per day for breakthrough pain, clonazepam 2 milligrams, Soma 2 tablets 3 times per day, Lunesta 3 milligrams, sleep at night. His records indicate he has had multiple epidural steroid injections over the past 6 years, as well as an unsuccessful spinal cord stimulator trial. James has recently moved to Montana, looking for the good life, and is looking to establish care with a new physician. He is in the process of applying for Social Security.
He was in my office last week.
Right. I referred him. So, tell me, I mean, I think everybody has seen this, because, I mean, we get a ton of these folks who have moved from out of state, and they're, you know, they're just, every primary care physician just hates to see this show up in their office. So what do you need to know?
Did he forge the letter from his doctor?
No, but it was written on a typewriter.
Well, but you know, so that's the question. Do we believe this guy? And you know, we've heard all day that, you know, to some extent you got to believe this guy.
And I'm saying that this is all legitimate information.
Yeah.
I'm not even saying that this is legitimate information.
Does he have medical conditions that this would be dangerous, like obstructive sleep apnea or something like that?
Probably. He's never had a sleep study though, and nobody's really asked him about whether he snores or anything like that. What's that? Yeah, but he naps a lot, so he figures it's okay. Unless you like to treat fibromyalgia with OxyContin 80 milligrams. Yeah.
I'm not sure what I would do with this fellow, but let me point out that he is at extreme risk for unintentional opiate overdose. Now, this is a person who could wind up dead. He's on a lethal combination of medications. He is tolerant of them for now, but change the balance even a little amount, and this guy could be, you know, he could wake up dead. This person is really at risk.
And the person that was seeing him was banking on that.
I think the first,
first time you meet with this gentleman, I'd be hesitant to change anything radically. I would try to develop a relationship with him, look at his medications. What is his goals by moving to Montana? And is it to be sitting on the couch for the rest of his life? Or are there other things that could go? And you could mention the fact that there are other medications that may be useful that you could then eventually change. But I think we've had enough chronic pain patients who show up in your office and you're going, okay, there's enough valid history here, I can't argue against it. Yes, he has a lot of risks, but at this point, if you went, no, I'm gonna change something, he's out of there and you won't see him again. So if you really want to effectively change something, I'd give him a shorter amount of medication, hope to see him again, and then work on potentially switching him from OxyContin to maybe methadone. Cost could always be a factor. Look at other modalities that, such as, whether an SSRI or Savella, will try something for his fibro. But I think you really have to look at, one, you have to develop a relationship, two, and try to identify why did he move to Montana.
I agree. I think we need to find out functionally. If he moved to Montana to enjoy the good life, we expect him to be more functional. Why is he getting on Social Security? What is it that's limiting him? And can we make him more functional than he is if he's not?
Except one thing, I would definitely get rid of the soma. I would at least change the soma, or, at the first visit, that needs to be addressed. And, kind of educate him about what could happen with soma and accommodations, and maybe at least try some tizanidine or something. Switch that out.
Okay. Dr. Mulder?
It's not.
I think what you're getting at with a case like this, these are oftentimes the most complicated patients sometimes that you see. They can be very actually very rewarding to treat. I find that they come really in basically 2 of 3 categories. The first category, these patients actually do want to get better. They're just on the wrong combination of medications. And you can establish a relationship with those people and you can get them plugged into physical therapy, usually not on the first visit. And they do okay. I've had a number of people like this that you convert their medicines over to a more appropriate regimen, whatever that might mean to you. They do okay. The second group is a little bit more difficult. Some of these people are frank drug addicts, and I think that the people that have been prescribing the medications to them practice very shady practices. I've certainly seen notes on people like this. There's no MRI, there's no X-ray. I just saw a patient in my office like this, and it was just a photocopied form and a couple of check boxes, and patient doing okay. And those patients, they're either going to scream and yell at you if you push them too hard, and you're not going to have a good experience. So if you recognize that they're not going to be with the program at all, at least try to end the conversation as politely as possible, but you may not be able to. But a lot of these people, though, if you can get them, and you can work with a licensed chemical dependency counselor, and you can establish a rapport, enough of a rapport with them to get them into an LCDC, and they'll go, you can have a pretty good outcome. Now, what do I mean by a pretty good outcome? I'd say in patients like this that walk in my office, it's 50-50 whether I can help them.
Well, and that brings up the question that nobody truly brought up. I mean, we're all sort of assuming we're going to take this person, and what I'm seeing going on in Montana is that the primary care practitioners look at this, and first they probably won't let them pass the front door. And the second is that if they take them, they're immediately saying, I'm not treating you, I'm going to give you enough medications to get to the pain center, and then I'm not going to refill it again. So part of the question is this gentleman does this person have that bar on the chemical substance problem way high, and we're just ignoring it because he comes with records. He comes with records that look like he's a patient that has no drug-seeking behavior, and then you look at the regimen and you say, doesn't make sense.
Randall, 2 quick things. First of all, I think he needs a good assessment of what's really going on. But the second thing, June is over here kicking me about this, but the second thing is that in Missoula, that's what happened, where they go to see the primary care doc who says you got to get over here. In Bozeman, I'm sorry, they come see Heather, who works in my office with me, and that's where we are, so.
Well, and the problem is the same. I mean, I think that one of the issues is somebody that presents this way and hands you a package. I just wanted to get a feel for what people feel like it's their responsibility to do to essentially take somebody off the street with a package and says, this is who I am. I mean, what's your tolerance for saying, okay, let's start from where you are and work from there versus saying,
yeah.
I mean, I know what my experience is, but I guess.
I guess I would just dissent a little. I don't think we have any professional obligation to believe him. In fact, I think we have a professional obligation to doubt, question, and verify everything that he's given us. And if we decide to take him on as a patient, then I think we have an obligation to look at all of his records and see what needs to be redone, if anything. And that's where the burden comes in. It's easy just to give him drugs. But because he's at risk to himself and others. So yeah, I think we have to doubt whether or not things have been managed or whether he's even truthful.
Well, I think that's two different issues. I think, as Dr. Mulgrew said, we're always caught in the position of trying to see where the pathology was. Was the pathology with the patient, or was the pathology with the person that was treating him? And what else?
I have a quick comment. I mean, I'm just kind of reiterating what was said, but for me, if I saw this patient, the first thing I'd have to be convinced is, what am I treating? Obviously, review the records, do a good exam, know what you're getting into. I think confirm his story. I'd probably call the physician that was treating him. Our clinic, before we take on opioid prescribing for a patient, there's a few things they have to do, and it's actually worked pretty well. One, we urine drug screen everybody before we start writing opioids, and we actually use Ameritox, but these companies that can do the gastrochromatography and break it down, and you can actually see what drugs they're taking, and it is amazing how many drug screens we get back that, he says he's taking OxyContin dilaudid, and you'll get it back and says he's taking OxyContin, no dilaudid, but he's got methadone. I mean, we see that routinely. It's scary. But that can be a very useful tool in A, making a decision where you're going to take this patient on, but also B, in compliance. And that's the main point that I think that I had.
Randy, are you aware of DEA stings in Montana with a scenario like this?
About what?
DEA or ATF stings. I've heard physicians, where a guy comes in and while we're traveling.
Stings.
Yeah. That's the other thing I'm worried about. You hear these things, and I don't know, but it's like no verification, and that's the whole setup. This is my wife and I, she's got chronic pain, and, could you go ahead and fill these scripts and, no identification, no records, nothing verifiable. How much, I feel like I've got a target on my back a lot of times.
Yeah, no, I hear you. What else? Any other comments on this case? Yes?
Well, you guys got a red line dash indicator for the substance problem, and if this were any problem other than pain, primary care would say, if somebody showed up and said, I want you to run chemotherapy for my osteosarcoma, we would all say, no, I can write prescriptions, but I'm not going to coordinate this level of substance problem. I think one of the things a lot of us with primary care are hoping for from this is, like you say, there's 120,000 primary care doctors, there's 6,000 pain specialists. This is somebody where even if everything is absolutely pristine and this guy is doing all of this legitimately and his doctor was a nut, how do we, I think we're coming here looking for some guidance on this very question, which is how do we do this on our own?
I think this is probably one of the hardest problems that decision-making problems that we see, because we've adopted just a hardcore, we don't prescribe on the first visit. Now the bottom line is that we feel like that a person like this needs to make these arrangements before they move. And that's what we do with our patients, that we are transferring, and if we think, we can stand behind this, we don't just give them a packet and say go. So that's one way, but things change. Everybody sort of, And we get patients that leave some other state for all sorts of reasons, and they didn't have the benefit of doing that. And I understand that occurs. But the problem you get is what's happening. You get the primary care practitioners who feel compelled to sort of help this person out and bridge them. And my only concern is I'm not certain that's solving the problem. I think it's creating this sort of no man's land with patients who are able to sort of bounce around for a little while doing that. But in the end, there's no home for them to land in. And when they come to us, it's kind of like, you know, I'm sorry, but whoever wrote that last prescription is going to have to detox you because it's going to take us 6 weeks to get you through the process, and we're not going to prescribe during that period of time. And I understand that's pretty cruel in some ways, but it's the only way for us to really maintain any sort of control over the situation. Yeah.
What about making a phone call to the previous doctor?
Yeah, I mean, that's always a possibility. I mean, obviously. But again, I still look at this and I say, I don't care what the doctor says, this doesn't look good to me.
Okay. We have two sides to this question. We have the unknown patient and then the irrational polypharmacy.
Right.
And I've sat across from over a triple-digit number of irrational polypharmacy patients that walked in that I could verify where they came from. And I think we need to address that question too, because we can't just say no to the patient, but at the same time we have an obligation to our conscience to never engage in irrational polypharmacy. And addressing that sensibly, I think, is challenging. And I think we need to think about what is reasonable. Take out the California.
Correct.
Take out the non-verifiable records. You have this patient who's on too many meds, too much polypharmacy, meds that should never be given, meds that should never be given together. Do you sit down? I mean, where I ended up after dealing with a triple-digit number of these is that you sit down and figure out what is safe for them, an appropriate opiate dose and an appropriate adjuvant so there's no withdrawals. And so at least you start somewhere, then get the full workup going, get the neuropsych eval, get the addiction counseling, and take it or leave it, and some take it, some leave it. Is that reasonable?
And here's the other question. Is your point of starting detox, or is your point of starting where this is?
I think you can go either way. I mean, I took the point of starting is where this is, so you calculate an appropriate opiate dose so they don't have withdrawals, and work from there. And if they're going to get to detox, let that happen. So give them enough chance to fall in line with rational pharmacology.
Yes.
I wanted to address what you were saying. It's similar to that. You can just give me one.
Well, we know none of us in this room have ever contributed to irrational polypharmacy.
I think just, what does a good outcome look like with someone like this? I just want to mention that because we all know what the bad outcome looks like. I think we've all seen that. I have had patients with very similar backgrounds come to my practice, and if you can establish a rapport with the patient, that's critical. And so we'll assume that you can. Yes, you establish a reasonable amount of medication to give to these patients. A lot of patients actually do better if you use the medicines that we were talking about earlier. If you convert them to long-acting opiates, I personally I don't believe in breakthrough opiates for chronic non-malignant pain. I just think that they don't work well. Somebody needs to look beyond opiates. I do use them occasionally. If you can add in a tricyclic or an anticonvulsant, and then you can reestablish them into the social system, i.e. they go to physical therapy and you get them connected to vocational rehabilitation. Now what's the odds that this patient in this scenario wants to go through all that? It's low. I mean, that's been my experience. These patients are not people walking the door wanting to go through that. But if you can establish a rapport with them, I have had a number of patients that you can reconnect into the medical system. And the biggest thing on the first visit is you have to establish a trust, and that's a two-way street. As a physician, you have to trust that that patient will take the medication that you're going to prescribe to them as prescribed. And they're not going to sell it on the street, and they're not going to take extra medicines. And whatever you need to do to feel comfortable with that. But then the patient also needs to feel comfortable with you as a doc. And if you can't establish that basic level of trust, I won't give a prescription for a controlled med if I don't trust the patient.
Any other comments, questions?
It's 10 after 5, just so you know.
Okay, all right. So we'll wrap this up. Thanks for participating. Enjoy the rest of the conference, and if you have any questions, everybody will hang around for a little bit or grab them in the